Testing, testing. Testing. Ya, audio dekat mana? Ya. Detect suara sini, laptop ini.
Ya, cuma
Kuat sikit.
okey dah.
Oh. Boleh.
Tidak ini. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. To our honorable guests, timbalan-timbalan pengarah, ketua-ketua jabatan, pakar-pakar, pegawai perubatan siswazah, staff nurse, paramedik dan semua kaki tangan Hospital Raja Perempuan Zainab II. Thank you for joining our CME session for today. My name is Dr. Najidah Hanum from Jabatan Kecemasan dan Trauma HRPZ, your moderator for today. First and foremost, we start our CME session with a simple doa, Rabbi zidni ilma. Before we proceed, just a gentle reminder to all participants to scan QR code displayed on the screen before and after the CME for the attendance, or you just simply click the link provided in the YouTube live chat box. If there are any questions from our online viewer, kindly leave your question in the YouTube chat box and inshallah I will read in the end of the presentation. Now I would like to introduce our honorable speaker for today, Dr. Chin Yize, our trainee intensivist, who is going to present a topic entitled shock. Without further ado, please welcome Dr. Chin.
Terima kasih. Okay, a very good morning to all the head of service, head of departments, consultants, and my fellow colleagues. Thanks the hospital for inviting me or giving me the slots to present today's hospital CME. So I chose this topic of shock because shock is associated with significant morbidity and mortality in our patients. But more importantly, shock is easily treatable if it's diagnosed early and if the initial resuscitation is carried out accordingly. So without further ado, we will talk about the crashing patient, hemodynamic collapse. So this topic is not about a collapsed patient. If the patient has collapsed in front of you, just perform the CPR as per BRS and ARS protocol. So today we'll focus on shock. So we'll go through a simple definition of shock, a brief pathophysiology of shock because it's a 1-hour lecture, classification, which is important. So we need to classify our shock into 4 types of shock. Why? Because it will tell us the differential diagnosis, the provisional diagnosis, so that we can treat the underlying etiology, and more importantly, it will guide us in our management. And then we will talk a bit about the incidence of different types of shock and how shock manifests so that we can detect it early to further delay in management that result in significant morbidity and mortality. And I will introduce to you a simple initial management for all patients, and subsequently we can fine-tune the management for a better patient outcome. So when we talk about shock, we always think in a daily conversation that it is an emotional reaction to a stressful situation. But shock in medical terms, it's a clinical syndrome where there is an acute circulatory failure resulting in an inadequate oxygen delivery to meet the oxygen demand or utilization at the cellular level. So at the end of the day, there is cellular hypoxia. So what contributes to shock? Basically, the Again, based on the definition, there is an inability of the cardiovascular system to deliver the oxygen from the heart through the vessels all the way down to the microcirculation, where arterial, capillary, and venous has a larger play. This is where the diffusion occurs between the capillaries and the cells. And finally, the cells need to be able to extract the oxygen and to use it to produce ATP as energy source through the oxidative phosphorylation process. So any dysfunction from the heart to the vessel, to the microcirculation, and to the cellular level will result in shock. Because at the end of the day, cellular hypoxia occurs, tissue hypoxia occurs, and organ hypoxia occurs if there's not enough oxygen delivered to the cells. And this, if you allow it to escalate, it will result in multi-organ failure and death would be inevitable. The good news is shock is often reversible as long as we diagnose shock early and initiate appropriate treatment. And this will increase patients' chances of survival. So now let's go to the classification of shock. So pay attention, this is the important slides. So shock can be divided into hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock. So Weil and Shubin has classified shock according to these 4 states. Distributive shock is where there is a relative hypovolemia in the effective circulatory system because there is vasodilatation at this level. So when the vessels are dilated, because they lose the vascular tone, then patient will be hypovolemic, subsequently inadequate oxygen will be delivered to the tissue. The other pathophysiology behind distributive shock is capillary leakage. So when the vessels are very leaky, fluids will be lost through the capillaries to the interstitial space. And that will also result in hypovolemia, hypotension, and subsequently shock. And capillary leakage is a hallmark in sepsis, whereas vascular tone also happens in sepsis, but also in anaphylactic shock as well as neurogenic shock. So the next commonest cause of shock is hypovolemic shock. This is an absolute hypovolemia in the circulating system. So there is not enough either blood, plasma, or fluids in the body, resulting in inadequate oxygen delivery to the cells. Sharing the same percentage would be cardiogenic shock. This is because, in simple terms, pump failure. Why would the hearts fail to pump enough oxygen to the cells? Basically, it's either a myocardium problem, for example, ST elevation MI, or valvular problem, let's say severe aortic stenosis, severe aortic regurgitation, hence the heart is unable to pump enough blood and oxygen to the tissues, or it can be conduction problem, let's say ventricular tachycardia or bradyarrhythmias. So this results in cardiogenic shock. Rarely, patients will present with obstructive shock. Obstructive shock is the obstruction of blood flow out of the heart. Maybe right heart or left heart. So think of the right heart, what can obstruct the flow? Acute pulmonary embolism. How about the left heart? You think about aortic dissection. So there is an obstruction to the flow, and as a whole heart, pericardial tamponade. So 2% of patients would have obstructive shock. So whenever you see a patient in shock in front of you, try to classify them into one of these shock because it will tell you the differential diagnosis and more importantly, help you to manage the shock in front of you. So because this is an important concept, let's just go through in another diagram. So shock again, hypovolemic shock, distributive shock, cardiogenic shock, and obstructive shock. So for hypovolemic shock and distributive shock, it is a volume problem. It's either an absolute loss or a volume shift. Whereas in cardiogenic shock, it is an output problem in the heart system. Obstructive shock, it is an output problem outside the heart, causing it to impede the flow of blood to the vascular system. So for hypovolemic shock, how would the patient lose volume? Can lose blood in traumatic hemorrhage or non-traumatic hemorrhage. Traumatic hemorrhage means that there is an organ lesion. For example, in polytrauma, there is a liver contusion, splenic rupture, causing hemorrhagic shock. Why they differentiate these two? The author wants to distinguish these two because if there is a solid organ lesion, the organ itself, the tissue damage will also release inflammatory mediators. So the patient will not only be in pure hypo or hemorrhagic shock, they may be in cardiogenic shock because of the inflammation or respiratory shock. So it's a mixed type of shock. Whereas if the patient just lose blood from, let's say, peptic ulcer bleeding, so we secure the bleeder, we transfuse blood and blood product to stabilize the patient. This type of hypovolemic shock is easily reversible. Patient may lose body fluid alone. Let's say patient has GI losses from projectile, persistent vomiting, persistent diarrhea, inadequate fluid intake. Or patient may have plasma loss predominantly. This can be seen in traumatic hypovolemia, for example, burns. So distributive shock, the patient may lose the permeability capacity, and this is a hallmark in septic shock. They may also lose the tone, as mentioned earlier, as seen in anaphylactic shock and neurogenic shock. How about output shock? In cardiogenic shock, there's a problem with the myocardium in acute coronary disease or in cardiomyopathy. Conduction system, if patient has severe bradytachyarrhythmia, it can also result in cardiogenic shock. And as mentioned earlier, a severe chronic or acute deterioration of chronic heart valve disorder can result in cardiogenic shock. Obstructive shock can be due to tamponade, can be due to the acute pulmonary embolism and aortic dissection, resulting in failure of the heart pumping out the blood to the vascular system. So this is just the different type of shock and the causes, the common causes. So when we look at shock, majority of the patient will be in septic shock, followed by cardiogenic shock at 16% and hypovolemic shock at 60% as well. Rarely they can present as neurogenic shock, anaphylactic shock, and obstructive shock. Okay, so how do we diagnose shock? It will be obvious if the patient is in hypotension, whereby the systolic blood pressure is less than 90 and all the mean arterial pressure is less than 70 mmHg. Often it is associated with tachycardia as compensation. What if the patient is normotensive or the patient is relatively hypotension because patient has chronic hypertension? So we look for an organ perfusion damage. This can be seen in what we call the 3 windows of signs of hypoperfusion. So there's not enough oxygen to the brain, patient has altered mentation. They can present as confusion, delirium, agitation, reduced conscious level, coma. Then look and touch the skin. In shock, patient would have cold and clammy skin, mottling skin, or increase in capillary refill time. This is a simple bedside maneuver you can do, but it is able to detect shock. And lastly, look at the urine. If in adults there is less than 0.5 mL per kilo per hour, then it may tell you that the patient has shock. So 3 signs, 3 windows of hypoperfusion, abdomination, skin, or oliguria. And we can also look into the surrogate markers of inadequate oxygen delivery, increase in lactates. So back to the clinical manifestation, how would different type of shock manifest? So distributive shock, hypovolemic shock, cardiogenic shock, obstructive shock. So whenever we see a patient who's in shock, we need to think about what is deficient. So back to physiology, mean arterial pressure is a product of cardiac output and systemic vascular resistance. So if the patient is having distributive shock, the systemic vascular resistance will be low, and that will be treated with either fluids or vasopressors or both. If you think that the patient is having a cardiac output problem, but the systemic oxygen resistance is good, then think of stroke volume deficiency or heart rate disorder. If patient having tachybradyarrhythmia, treat it accordingly. When we think about what contributes to the stroke volume, it is due to preload. So preload is fluids or blood product. Contractility problem with the myocardium, think of inotropy, and afterloads. Maybe patient coming with hypertensive emergency, you need to reduce the afterloads to improve cardiac output. Another way to look at shock, if you have a patient in front of you with shock, is to divide them into either cold shock or warm shock. Just feel for the peripheries, feel the hands, feel the feet. If the patient is in cold shock, the problem lies in the stroke volume. So think about preloads, contractility, and afterloads. Maybe the patient in cold shock needs fluid, maybe it needs inotropy, maybe it needs to have inodilators. If the patient has warm shock, more often than not, it is due to the reduced vascular tone. And this is because there is a distributive shock where there is either vasodilatation, vasoplegia, or there is increase in capillary leakage. To further confuse you, you can further divide the shock into either cold and wet, cold and dry, warm and wet, warm and dry. Basically, wet means that the heart is not able to pump all the blood out forward, hence congestion back to the lungs. Dry is either the patient has too little volume in the body, or the patient heart is able to take in all the volume and pump it out forward. So how do you come to a diagnosis about which type of shock the patient is? Back to the basics. Get a good history, get the context of the patient, because different contexts will elucidate different type of shock. Look for the clinical examination, and I said earlier, touch the patient's periphery. Is it a warm shock or cold shock? And you can divide them into either a volume problem, heart problem, obstructive problem, or vasodilatation problem. And then investigation is there to aid us in our differential diagnosis. And more often than not, nowadays, we have a point of care ultrasonography. Okay, we'll get into that a bit later. So for example, if you suspect patient is in shock and you want to tell which type of shock is it. So for septic shock, we go back to the definition of shock of sepsis. Sepsis 3.0, which is you use the SOFA score, an increase of 2 or more, or SIRS criteria. Look for the source of sepsis. YSA count may be raised, CRP may be raised, and more recently we have the procalcitonin, which is more specific, but it's not 100% foolproof. Septic shock is usually warm shock because they are vasodilated, but if they have concomitant septic cardiomyopathy, or because of the relative hypovolemia, they can have also cold shock. So this is how you go about this. If the patient comes in with polytrauma, the first shock you think of is hemorrhagic shock. Patient may have concomitant neurogenic shock, may have septic shock, but it's usually later. So context matters. So I'll not go through that. You can read about that a bit later. So point of care ultrasonography, you've seen a lot of this in the ED, you've seen a lot of this in the ICU, and more often than not, now many of the wards will have it. So how is it useful for us? It will narrow down our differential diagnosis, because history and examination only can get you so far. It's not very clear over the slides here, but I hope you can see that the first echo here shows, and when we do echo in critical care, we are not really wanting to do a detailed image. We don't want to get all the information that we need. We just want to answer a few questions. For this topic, we want to answer what type of shock is this patient having, and what are the possible diagnoses for this patient. So for the first echocardiography, we can just say that this patient having a very poor heart function. It means the ejection fraction will be probably very low. And if the patient is in shock, you probably need to think about inotropy, and fluids is not the answer. If you see the other diagram here. There is, I hope you can see there's a bit of pericardial effusion, but there's no tamponade there. And the heart function is relatively good. The contractility is good. Volume, difficult to say, but if you want to give a bit of fluid, you want to support patient with inotropy, you can because of a bit of obstructive shock, but it's not in shock yet. This view here, plus this view here, can tell us about whether this patient having a right heart strain. So if suspect patient having acute pulmonary embolism, basically we want to ask ourselves the question, is this patient having a massive pulmonary embolism or not? Because massive pulmonary embolism, the treatment will be thrombolytics, and that will significantly reduce the mortality of the patient. So we can look at the change in the crescent shape of the right ventricle. We can look at the septal deviation. We can look at the corneal sign. And lastly, we can look at the whether patient is fluid responsive or not. And if we do a serial ultrasound in our patients in shock, we can look at the response to therapy. So for the novice, in the use of ultrasound bedside, we can first familiarize ourselves with few protocols, but just pick one, master it, and put the puzzle together. So basically, point of care ultrasonography is just to give you extra information quickly at the bedside. It will not tell you 100% what the diagnosis is. You still need to go back to the basics of history taking, physical examination, support with some investigation, and this ultrasound will guide you. So septic shock, patient will likely be having hyperdynamic hearts, or if the patient having concomitant septic cardiomyopathy, patient will have global hypokinesia. Whereas in cardiogenic shock, if the right context, let's say patient having acute coronary syndrome supported by ECG and high trop I with a cold peripheries, and you look at the echo, the heart contractility is poor, there's no valvular lesion, then you can safely say this is patient having cardiogenic shock, and the treatment is tailor-made according to that. So far so good. So we talked about the definition of shock, a brief pathophysiology, more importantly, how you diagnose shock, basically hypotension, 3 windows of signs of hypoperfusion, guided by the lactate level. And then importantly, we need to know how to classify shock so that we can have provisional diagnosis, differential diagnosis, and we will guide our management. So how do we manage a patient who is having shock in front of us? Well, they propose this theory about VIP mnemonics. Okay, so basically, what's the goal? The goal is to improve blood flow and hopefully microcirculation flow so that the oxygen can be delivered to the cells. And whenever you have a patient with shock in front of you, think of what is deficit. Is it a problem with the systemic vascular resistance? Is it the problem with the cardiac output? Can it be because of the preload, contractility, or afterload, or tachybrady arrhythmia? And we treat accordingly. So the VIP approach to bedside management of shock. V is short for ventilate, I infuse, and P for pump. So when we talk about ventilate, we're not talking about intubating everyone with shock. We support them with ventilatory support. So what's the aim? The aim is to optimize cellular oxygenation in circulatory shock. Basically, we want to increase the fractional oxygen that can deliver to the patient, so that hopefully the cardiovascular system is enough to push the increase in oxygen to the blood, to the cells. And some patients will have hypoxic pulmonary vasoconstriction. It's a physiological mechanism to protect the lungs. So by giving them extra oxygen, you are preventing pulmonary hypertension, hence favoring forward flow of the right ventricle to improve the cardiac output of the left. So how do we support the ventilation? We can give them as simple as oxygen supplementation, venturi mask, non-rebreather mask with high flow mask, or we can provide them with non-invasive. For example, hypronasal cannula or NIV, such as a CPAP mode or BiPAP mode. So this oxygen supplementation and non-invasive ventilation has a role in the initial phase of shock. As I said earlier, don't induce and intubate them whenever you see a patient with shock. Give them some oxygen first, tackle the other component of shock. But if the shock persists or there is a worsening of shortness of breath, hypoxemia, acidosis, then an invasive ventilation will benefit the patient. Why would we want to ventilate them? We can improve the oxygen delivery because we are giving them adequate oxygen. We reduce the oxygen demand because as a compensatory mechanism of shock, the diaphragm and the lungs and the cardiac respiratory system need to work harder to get oxygen from the atmosphere to the heart so that the heart can deliver oxygen to the body. So when we intubate, ventilate, sedate them, we are reducing the oxygen needs of the respiratory muscle. They don't work as hard as much, so that they need less oxygen. And because of the heart-lung interaction, you reduce the left ventricular afterloads because it reduces the transmural pressure of the left ventricle. However, we're not asking everyone to intubate all patients in shock unnecessarily. Why? Because if the patient is intravascularly depleted, the drugs itself and the ventilation itself can cause a circulatory collapse. So preload them properly, resuscitate them first, then only we intubate them. And prolonged ventilation is associated with an increased risk of ventilator-associated pneumonia, which has its own morbidity and mortality, and ICU-associated weakness. Okay, so that's B. Let's go to I, infusion. What are we infusing? Basically fluids. When we talk about fluids, we think about what type of fluids are we infusing and the amount that we need. So just a brief classification. IV fluids can be divided into blood and blood products or non-blood IV fluids. So if patient is having hemorrhagic shock, of course, give blood and blood products. And of course, we try to secure the bleeder to avoid a spiraling deterioration of hemorrhagic shock. If it's non-blood, then we ask ourselves whether we want to give crystalloids or colloids. So crystalloids can be subdivided into hypotonic, isotonic, hypotonic, whether the crystalloids having glucose or not. And nowadays, the debate is whether we should use 0.9% saline or balanced solution. Colloids can be gelatin-based, albumin. The starches is no longer in use, and dextran is rarely used in our day-to-day practice. So what we have here in Malaysia, we have 0.9% saline and Hartmann for crystalloids. We also have sterofundin here, but it is also debatable whether this is balanced or not. At the end of the day, this is the crystalloids that we have here. Colloids, what do we have? We have gelatin-based like gelafundin and albumin. So this is just a table about different type of crystalloids, different type of colloids. You can read by yourself. So what type of fluid we give is still a great debate at our parliament. And that has resulted in many landmark trials to try to answer the question, which type of fluid is the best for patients in shock. So these are the trials between balanced crystalloids and 0.9% saline. Summary is, none of this has shown to improve the mortality by using balanced crystalloids. Maybe preventing in acute kidney injury, maybe preventing in the need of RT, but the evidence is not very robust yet to phase out 0.9% saline, and we still use 0.9% saline in our day-to-day practice. But bear in mind, 0.9% saline has its problem. Hypochloremic acidosis is one, maybe some acute kidney injury is the other. So you can use balanced crystalloids for the others, except in patients with traumatic brain injury, or if you want to protect the brain, then 0.9% saline is still the way to go. Crystalloids or colloids as a fluid for resuscitation. The crystal trial has been done. It doesn't crystallize the answer. The verdict is still out there. It doesn't improve mortality by using colloids, so usually we use crystalloids first. Albumin versus crystalloids. Again, no mortality difference in outcome. Verdict is still out there. You can use albumin if a large amount of crystalloids has been used. The only cases that you don't use albumin is in traumatic brain injury. It's associated with increased mortality. Test has been phased out because it's associated with kidney injury and the need for RRT. So in summary of type of fluids, what do we give? Verdict is still out there. Probably crystalloids will be the first choice of initial resuscitation. If you have the means, go for balanced solution. If not, 0.9% saline is fine. Of course, if the patient coming in hemorrhagic shock, the answer is not fluid, the answer is blood and blood products. Okay, how about the amount? How much volume to give? So when we talk about volume, it's a difficult topic. We don't really know how much the patient needs. So we thought the more accurate way is to look at fluid responsiveness. So what is fluid responsiveness? So Paul A. Merrick, who is an intensivist superstar, he proposed that if there is an increase in stroke volume of cardiac output of more than 10%, after we give a bolus of, let's say, 250 to 500 mL in 20 minutes, then patient is fluid responsive. Why? Because it's based on the Frank-Starling curve here. If you stretch the left ventricle at the end of diastolic ball, the heart will contract and pump out the fluids. Whereas if the patient is fluids repleted, that means they are intravascularly filled. By increasing the stretching of the heart muscle, it will not result in the increase in cardiac output. And this is the plateau surface of the Frank-Starling curve. What if patient has cardiac failure? It will still work. If patient is intravascularly depleted, you give a bolus of fluid here, there is still increasing cardiac outputs. But the curve will become the plateau faster. So be careful of the volume of fluid that we give if patient having cardiac failure. Fluid responsiveness, static parameters. In the past, we used to use pressures like CVP, heart rate, blood pressure to say whether this patient is having fluid deficit, but it is as good as tossing a coin because sensitivity is only 50%. So if the patient is having heart rate of 120 beats per minute, 50% of them is volume depleted, 50% of them will be volume depleted. So it doesn't really help us in our day-to-day practice whether this patient with poor unit output is having shock or not. Also, does it need fluid or not? So better way to detect fluid responsiveness would be dynamic parameters. So of all these 5 main dynamic parameters, I think outside ICU, fluid challenge test and passive leg raising would be the way to go. So as mentioned earlier, if you give a fluid bolus, let's say 250 mL over 10 minutes, and if there's an increase in stroke volume, cardiac output, then patient is fluid responsive, you can give some more. So you give some more, it's still fluid responsive, up to a point where when you give, stroke volume is less than 10% increase, they are non-responsive. So stop giving fluids when the patient is in this part of the curve. Now, passive leg raising can be done anywhere in the ward, in ED. So basically what happens is you measure the stroke volume, but stroke volume you can't really measure outside the ICU. You need cardiac output monitoring. So what you can do is you can use pulse pressure. So pulse pressure, let me go through this. Pulse pressure is the difference between systolic blood pressure and diastolic blood pressure. So if the patient is hypovolemic, that means they are fluid responsive. What happens is the heart is not stretched enough, it doesn't pump enough blood. So the systolic blood pressure will be low, and as a result, the body is trying to perfuse by increasing the tone of the vessels. Diastolic blood pressure will be high. The pulse pressure here will be narrow. After you give the fluid, or in this case, passive leg raising, the left ventricle is stretched, and hence the cardiac output will be increased. So systolic blood pressure will increase. As a result, the vessels doesn't need to be constricted as much, and diastolic will be increased. So the pulse pressure will be increased. So after giving a fluid bolus, if the pulse pressure increase, that means patient is fluid responsive. Back to the business of passive leg raising. So first, you need to get a pulse pressure before you do anything at the semi-recumbent position. Then you tell the patient, because patient may not be sedated, they may be awake, that you want to do a passive leg raising, tell them what it entails. Then you lie the patient flat, and we raise both legs up passively. That means we, as a clinician, will raise the both legs up for 30 to 90 seconds. After that, we will measure again the pulse pressure. So what it does in this diagram here is it auto transfuse the patient's blood about 250 to 500 mils of both legs to the heart so that the heart can pump out the blood. So the beauty of this is reversible. Once you put the patient leg back down, the volume goes back down. Why? Because in some patients, they cannot tolerate extra volume. So if this patient is fluid responsive, a passive leg raise will increase the pulse pressure to more than 12%. Then you can safely give the patient volume. If it doesn't, don't give any more volume. The answer is not fluid. Pulse pressure, as I said earlier, measure the pulse pressure before we do the passive leg raise. If there's an increase in 12% or 10-12%, patient can get more fluids. Sensitive and specific. So it's reliable. You can do it in a spontaneously breathing patients. It's not affected by arrhythmias. But you need both legs. If the patient has history of AKA, forget about it. It's not for a patient who has a raised intracranial pressure because you increase the intracranial pressure, raise intra-abdominal pressure, cardiac pressure because they're not stable. Or patients need to be lie on the bed for 6 hours. Let's say post-angiography, patient has intra-aortic balloon pump, and it's not reliable if the patient is severely hypovolemic. Just give the volume first. I wouldn't go through this because this is more critical care. Okay, so in summary, infusion, what we give, patient with shock, we give crystalloids first. Just give 250 or 500 ml bolus and look for fluid responsiveness. If they are, give some more. If they are not, go to pump. So the pump is we are infusing vasoactive agent or inotropic agent or both. Basically, vasoactive agent, we are trying to squeeze the vessels. Inotropic agent, we are trying to increase the heart pump. The goal of giving them vasoactive or inotropy is to increase the mean arterial pressure to more than 65 milliliter mercury or higher if they are chronically hypertensive. Why? Because the organs depends on certain mean arterial pressure for autoregulation. So between 65 and say 150 here, they have adequate perfusion. Less than that, hypoperfusion, more than that, hyperperfusion. But this is not a target if the patient is actively bleeding. We will initiate damage control resuscitation until surgical control can be obtained or interventional radiology can be done. So what type of vasopressors or entropy would we want to choose? We need to have some basic physiology and pharmacology knowledge. So the heart needs to have enough conduction, chronotropy, dromotropy, AV conduction, inotropy, enough contractility, and enough relaxation. And all of them are mainly by the beta-1 receptors. So if you want to improve chronotropy, dromotropy, inotropy, lucitropy, we need to give something that will stimulate the beta-1 receptors. For example, isoprenaline, adrenaline. How about vascular? We want to stimulate the alpha receptors causing vasoconstriction, but a beta-2 receptors will cause vasodilatation. Just go through briefly. Basically, you need to tailor the use of vasopressors or inotropy based on the pathophysiological shock or disease. Distributive shock probably need vasopressors, hypovolemic shock, fluids, blood. You can buy time with some vasopressors, cardiogenic shock, inotropy, obstructive shock, maybe inodilators, but more importantly, treat the underlying problem. If it's a PE, thrombolysis, if it's tamponade, pericarditis. So noradrenaline will be the vasopressor of choice for most conditions. It has a predominantly alpha adrenergic agonist, that's why it vasoconstrict, and a modest beta adrenergic agonist, increase inotropy. So it's good. 2 birds, 1 stone. You can use adrenaline as second line or in anaphylactic shock. Vasopressin can be used as second line if the vasodilatory shock is predominant. Dopamine no longer recommended because it doesn't improve outcome. In fact, it may increase arrhythmias and maybe mortality in cardiac shock. Ionotropy, dobutamine with or without noradrenaline would be ideal. However, dobutamine will also stimulate the beta-2 agonist, causing vasodilatation. So if the patient having vasoplegia, we tend to go for adrenaline as ionotropy. Moving on, levosimendan, just know that there are some drugs out there that we can use to fine-tune the shock. In some cardiac shock, problem is there's high systemic vascular resistance causing or high afterload. The high afterload will cause a reduce in cardiac output. So patient coming with hypertensive emergency, cardiac shock, we may start some GTN to improve the stroke volume. But it may reduce the arterial blood pressure, compromising tissue perfusion. Sometimes we may use intra-aortic balloon pump or VA ECMO to buy time for definitive treatment. So septic shock, as again, the problem is vasoplegia and leaky vessels. They may or may not have cardiomyopathy. So we give them volume, fluids, and then vasopressors with or without ionotropy, depending on whether they have septic cardiomyopathy. If the problem is the heart pump is not pumping adequately, we can start inotropes. Hypovolemic shock, as I mentioned earlier, fluids. Vasopressors can be started to buy time while your fluids goes in. Hemorrhagic shock, bloods and secure hemostasis, vasopressors inotropy to buy time. Anaphylactic shock, adrenaline would be the first choice of drug, but we can add on other vasopressors inotropy if the shock is refractory. Neurogenic shock, you need both ionotropy and vasopressor if the shock is high up. Let's say high cervical spine injury, then we can think about adrenaline, noradrenaline, or dopamine. Apoplectic shock, treat the underlying problem, tamponade, drain it. If it's active pulmonary embolism, thrombolyze it. You can buy time with ion dilator. Okay, should I go through this? So at the end of the day, what we want is we can start off with the ventilate support, infuse the fluid, and give some ionotropy or vasopressors. We want to deliver the blood and hopefully oxygen and nutrients from the heart all the way down to the tissue so that the cells can use it. Not go through this. Because of the interest of time, we just end this topic by having some take-home messages. So circulatory shock is associated with high morbidity and mortality. And more importantly, shock is reversible if it's diagnosed early and appropriate treatment is started early. To diagnose shock, it is obvious if the patient is having arterial hypotension, a systolic blood pressure less than 90 mm mercury, or mean arterial pressure less than 70. If not, look for the three window of shock, which is altered mental status, oliguria, and problem with skin perfusion. Cap refill time more than 2 seconds, cold clammy hands, and whatnot. And we can also use lactate to guide us in our diagnosis and resuscitation effort. If the patient is having shock, try to classify them into hypovolemic shock, distributive shock, cryogenic shock, or obstructive shock. Why? The diagnosis will be based on the type of shock, and the treatment will be as well. Lastly, I talked about the VIP approach. So give some ventilatory supports, infuse them with some crystalloids first, and if that fails to reverse the shock, start vasopressors or ionotropy. With that, I thank you.
Thank you, Dr. Chin, for the great and concise presentation. Since there is no question in the YouTube chat box, now I would like to invite Dr. Norzilawati binti Muhammad Ghazali to give away certificate of appreciation to Dr. Chin. Please welcome Dr. Norzilawati.
Thank you.
Thank you.
Thank you.
Selamat datang.
Saya 8 bulan tapi akan balik September. Yes. Yeah.
Thank you to Dr. Chin and Dr. Norzilawati. Before ending our session for today, I am proud to invite all HRPZ staff to join next week's CME session entitled The Ticking Time Bomb, which will be presented by Jabatan Kecemasan and Trauma. Thank you for your attention today, and we end the session with Assalamualaikum.